Hi, I'm Missy, and today we're going to talk about pediatric intubation. Before we get into the skill, I just want to review some pediatric anatomy that's really important for intubation and airway management in general. So let's first focus on children under the age of 2. The younger the child, the more different they are anatomically from an adult. Once a child's about 8, their anatomy is much more similar to an adult. And also from a physiologic standpoint, our children under 2 are a lot more dangerous to intubate. We have lower first pass success and higher rates of desaturation. So today we're going to intubate an infant. So let's talk about infant anatomy. First thing that comes to mind is that infants have a larger occiput compared to an adult. The goal for positioning is still the sniffing position. Generally for an infant, that means padding under the shoulders, but I also want to take a look from the side and make sure that I have good alignment of the ear to the sternal notch. So I may have to pad both under the shoulders and under the head to get that aligned appropriately. Once I have a child in the sniffing position, then I'm also going to think about the other anatomy that affects this procedure. They do have a large tongue compared to adults, but a big piece of anatomy that's different is their epiglottis. Infants have a floppy U-shaped epiglottis. Now compared to adults, our epiglottis and the hyoepiglottic ligament are formed in a way that inserting a Mac blade and lifting up in a way will engage that hyoepiglottic ligament. In an infant, that ligament is not developed, so instead of placing a blade in the vallecula, we're going to scoop the epiglottis out of the way. So that's why classically we use a Miller blade when we intubate children. Now you can use a Mac or a Miller to intubate a child, but if you're using a Mac, just remember you're not going to place it in the vallecula, you're going to scoop the epiglottis out of the way. You can also use a hyperangulated videoscope to intubate children, and we'll talk about that in another session. So let's talk a little more about that equipment. So I have my Miller blades here today, but again, you can use a Macintosh. Make sure whenever you're choosing your equipment, you're using either a length-based or a color-based system that accounts for the size of the child. So the sizing of equipment is very essential to its function when we're talking about pediatric patients. So for this infant today, I'm going to use a Miller 1. Keep in mind that the really small Miller blades, the 0 and the 00, are for neonates and newborns. So you're really not grabbing those unless the baby was born in front of you. So make sure you're using the right size blade. Next, let's talk about the ET tube. So we're going to pick the size of ET tube based on the tape. I'm using a 3.5 here today. And then make sure you open a size above and below what's called for on the tape. So if you need to pivot during your intubation attempt, you can easily grab for a larger or smaller tube. We're going to use cuffed ET tubes, and the reason for this is it helps secure the airway, improves ventilation. Only time we're going to use an uncuffed tube is when we have the size gray on the Broslow tape or your length-based tape, because the cuff itself adds a half size to your ET tube, so the gray just won't be small enough for those tiny infants. So with a cuff and then also with a stylet, and you're generally going to form this in the hockey stick position, or about 30 to 35 degrees, much like you would with an adult. We'll also talk about using a bougie for a child. So a bougie can be really helpful in adults to increase first pass success. And if bougie intubation is your first line in an adult patient, it's reasonable to make it first line for your pediatric patients. Keep in mind the pediatric bougie can only accommodate a size 4 ET tube. So if you have an infant that needs smaller than a size 4, you're not going to be able to use the bougie. And bougie can be preloaded like I have it here, or you can have a partner slide the tube over much like an adult. And then we're going to have our BVM ready. Use the BVM that's the correct size for the infant. And remember, your pediatric BVM should have both manometers and pop-off valves as well for safety. And we're going to hook that up to at least 7 liters per minute. We'll titrate up if we need to. And then lastly, our confirmation. So I like to set up my end tidal right on my tube so it's ready to go. Just like adults, end tidal is gold standard for children, but keep in mind there's some limitations. Based on the child's size or a child who's critically ill, they may not exhale enough CO2 to trigger this device. So if you're not getting a good end tidal reading, you may need to count on some low-tech confirmation. So watching the tube go through the vocal cords, misting in the tube, look at the child's overall condition. Are they pinking up? Do they have nice cap refill? Are you getting good saturations? Do you have normal lung sounds? So just know if the end tidal is not working, it may not be because the tube is in the wrong place. It may just be that the child isn't exhaling enough CO2. So now let's move on to the procedure of intubation with an ET tube and stylet. So when I'm performing this procedure, I'm going to walk down the airway slowly. This is because the glottic opening is very high on a child compared to an adult, and it's very easy to overshoot. So I'm going to insert the blade in the corner of the mouth, sweeping from right to left, walking down, finding the epiglottis and lifting the epiglottis up. Now I'm going to bring the tube in from the side so it doesn't obstruct my view, and I'm going to rotate it in and through the vocal cords just till the balloon goes through the cords. Now removing the ET tube, stylet, and I'm going to inflate the cuff just until I get some air to feel a little bounce. I'm going to take my device and I'm going to inflate the lungs just till I get gentle chest rise. Now I'll listen bilaterally and over the epigastrium, and ideally I'll get waveform CO2 as well. Just like we do in adults, if they are remaining hypoxic after an intubation, we can turn up the oxygen flow rate and gradually increase the PEEP. Next, let's discuss how to intubate with a bougie on a pediatric patient. Now, an important thing to remember again is a 4.0 ET tube is the largest tube that will accommodate a child bougie. The pediatric bougie is otherwise much like an adult, but a little bit less stiff. It has the upturned coude tip. I'm going to do a preload today, and when you preload, make sure you have at least a few inches of bougie out in front of the tube so that you get the benefit of that coude tip. Lube the tip of the bougie and the tip of the tube as well. So now let's walk down the airway. So I'm entering from the right side, scooping the tongue out of the way, finding the epiglottis, and gently sweeping the epiglottis up and away. And once I have visualization, I come in from the side, guide the bougie up through the vocal cords, and give it that little twist to the left as you insert the tube. After I pull my bougie out, I now can go ahead and ventilate my patient. So again, gently sweeping the bag, just a couple of fingers is usually enough, just until I get chest rise. Ensuring that you have a good end tidal CO2 reading, or using the low-tech techniques like misting in the tube, bilateral lung sounds, and generally look at the child's condition. Is their oxygenation and circulation improving?